Thank you for listening to the National Award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the April 2019 edition of PRS Journal Club podcast. I am Lily Mundy, PRS Resident Ambassador from Duke University, and I am joined by my co-resident ambassadors, Raj Parikh from Washington University in St. Louis and Kyle Sanniec from UT Southwest. Today we have the honor of being joined by Dr. Rudolf Buntic, Program Director of the Hand and Microsurgery Fellowship at the Bunty Clinic, Head of the Division of Microsurgery at California Pacific Medical Center, Associate Professor affiliated in Plastic Surgery at Stanford, and Clinical Faculty Member of the University of California. Thank you so much for joining us, Dr. Buntic, for this PRS Journal Club podcast.
Thank you so much for having me.
The articles that we will discuss can be read for free on prsjournalclub.com, including an archive of all past Journal Club articles. The next article we'll be discussing is Patient-Reported Outcome Measures for ToetoHand Transfer, a prospective longitudinal study which is from a group out of Changgung University in Taiwan with senior author Dr. Cheng Hung Lin. The authors performed a prospective evaluation of patients undergoing ToetoHand transfer from 2012 to 2015 for reconstruction of traumatically lost digits. The authors collected pre-op and post-operative patient-reported outcome data using the Michigan Hand Outcomes Questionnaire, a PRO measure that's designed to evaluate hand disorders, the SF-36, a generic PRO instrument that's designed to evaluate overall health status, and the Lower Limb Outcomes Questionnaire, which is a PRO instrument designed to evaluate orthopedic patients with lower limb conditions, with the Lower Limb Outcomes Questionnaire used specifically to measure donor site morbidity for this study. Inclusion criteria included ToetoHand transfer performed by an experienced surgeon with at least 1 year of follow-up with patient engagement and rehab, and no additional trauma or medical comorbidities affecting the outcome. From 2012 to 2015, there were 41 patients who met inclusion criteria, with 23 patients enrolled in the study. Mean patient age was 39 years, there were 16 males and 7 female patients, and mean follow-up time was 2.7 years. The mechanism of initial injury was crush in 83% of patients. The dominant hand was reconstructed in 13 patients and non-dominant in 10 patients. 9 patients underwent thumb with or without additional finger reconstruction, and 14 patients underwent finger-only reconstruction. 15 patients underwent reconstruction of 1 digit, 5 patients reconstruction of 2 digits, and 2 patients reconstruction of 3 digits. There was a total of 34 toes transferred, 9 great toes, 20 second toes, and 5 third toes. All patients underwent revision for aesthetic and or functional improvement, with tenolysis and pulpoplasty being the most common. The authors demonstrated improvement in patient-reported outcomes using the Michigan Hand Questionnaire and the SF-36, with no significant change in patient-reported outcomes of the donor site using the Lower Limb Outcomes Questionnaire. More specifically, the Michigan Hand Questionnaire demonstrated significant improvement in activities of daily living, aesthetics, and patient satisfaction, with a p-value of less than 0.05, but not in hand function or pain. The SF-36 demonstrated improvement in physical and emotional roles with a p-value of less than 0.05, but not physical function, vitality, mental health index, social function, pain index, or general health. 3 subgroup analyses were performed comparing dominant and non-dominant reconstructed hands, thumb reconstruction with or without additional fingers versus finger-only reconstruction, and use of great toe or non-great toe for donor site morbidity. In the dominant hand group, similar to the overall analysis, the Michigan Hand Questionnaire and the SF-36 demonstrated a significant improvement in PRO scores. In the non-dominant hand group, however, PRO scores did not significantly improve from pre to post-op. There were no significant differences identified between thumb with or without finger reconstruction and finger-only reconstruction. There was also no significant differences between great toe or non-great toe donor site morbidity. Overall, I thought this was a really interesting study. It's one of the first to prospectively compare pre- and post-operative patient-reported outcomes using validated patient-reported outcome measures in patients undergoing ToetoHand transfer for reconstruction of amputated digits. The authors asked important questions regarding which digit was reconstructed, such as the thumb versus a non-thumb digit, dominant versus a non-dominant hand, and use of the great toe as a donor site. The primary drivers and the benefits of ToetoHand transfer in the study seem to be ADL's work and aesthetic or socially oriented outcomes. However, hand function was not significantly improved with transfer. Additionally, reconstruction of a non-dominant hand was not found to be associated with significantly improved patient-reported outcomes. However, the authors noted a smaller sample size here and possibly not a high enough powered study within this subgroup. There are several limitations to the study. 23 patients is a relatively small sample size, and almost 50% of their identified patients who met initial inclusion criteria were not included in the study as they were lost to follow-up. So given this already small number of patients, this is a significant limitation here. Additionally, the exclusion criteria had an element of subjectivity, and it's a little bit unclear who may have been excluded from the study. Lastly, while the decision to use patient-reported outcome measures to evaluate these patients is commendable, it's possible that the authors didn't capture the full picture, since the patient-reported outcome instruments they used were designed to make general assessments of hand disorders and general health or lower limb disorders, as opposed to specific to trauma or for ToetoHand reconstruction. So Dr. Buntic, I just would like to turn it over to you and sort of hear what your thoughts were on the article.
This was a very interesting article, and what's so impressive is this group at Shangung, which is a real powerhouse group, even though number-wise you mentioned that it is a small number for statistical analysis, but is a huge number in a short time for ToetoHand transplants. And as you said, they are really the only people to look at these patient-reported outcomes before and after surgery. And for me, that was very interesting because we tend to use these objective measurements, and we use them preoperatively and postoperatively, and our hand therapists take range of motion measurements, and we take Semmes-Weinstein's tests and look at sensitivity and grip strength. And it's interesting to see what patients are reporting, and they seem to be telling us that they're really happy with the results of these ToetoHand transplants. And just as an aside, at the Bunty Clinic, we tend to use the term transplant rather than transfer, so sorry if that's a little bit confusing.
I agree with you in terms of the number that this is just sort of a rare procedure, especially for some of us here. What are your thoughts in terms of, maybe not their indications, but the types of patients that found value in this surgery, and what type of patient in your practice would you recommend to have a ToetoHand procedure?
The group that they're describing is very similar to the patients we see in our practice. We recommend ToetoHand transplants commonly, and of course, especially for thumb reconstruction. Some of our most grateful patients are those who've had ToetoHand transplants. But like everything in plastic surgery, every patient is different. These injuries are so complex. Recommending specific types of reconstructions can be difficult, and patients' comorbidities can make things very complicated. But really, this population is very similar to the ones we see, but the numbers are just so large for a very short period of time.
Kyle and Raj, I'm interested in what your thoughts were on the article.
Yeah, I thought it was a very interesting article. I mean, it's very different than the classic hand articles that we talk about because it is, like Dr. Buntic mentioned, very objective based in terms of prehension strength and things like that. And this is probably even more important in terms of what actually matters for patients is how they actually like the use of their hand and their new transplanted thumb. I guess my question and thought of Dr. Buntic, and I wanted to see what you thought of it, is the timing of this reconstruction. There's two schools of thought. That one is you do it rather quickly in the first couple weeks so they can have better functional results in terms of movement and things like that. And others say let the patient heal up, let the initial inflammation all go down, and then the patient can see kind of their disability without having a thumb so they can kind of appreciate the donor site issues that you have with transferring a toe up to your hand. So what are your thoughts on the timing of when you're doing these?
Those are really important points. Doing it early, you maintain a supple hand, and you potentially have an advantage of nerve regrowth being maximized. Doing it late does give patients a time to live with it. I think ultimately the answer lies with the patient. We see these patients acutely. They suffer these devastating injuries, and there's a lot going on in their mind and in their families and in terms of going back to work. And we can have long and complex discussions with them. We give them the option of doing both. And we tell them the risks, benefits, the alternatives, and ultimately we let them decide. We don't pick for them. For every patient, there might be a different solution. There might be a different waiting period. Some patients are very eager to go ahead with reconstruction quickly. Others appreciate the ability to wait some time, maybe get some things they have going on in their life in order before they take the time out to do this kind of reconstruction. There's a very big commitment time-wise and rehab-wise. Not only is the hand affected, the foot is affected, their ability to walk around, to do many things is affected for this kind of surgery, and sometimes planning on the part of the patient is good to have.
And then my other question with this regard is were there cultural differences in their patient group compared to what we see here? And at least in Dallas, it's been very infrequent that patients go ahead with a toe transplant for their thumb. With the use of prosthetics and camouflage and things like that, a lot of them aren't willing to undergo all the rehab and the challenges. And I wonder if there's some component of that and a different, like kind of a cultural bias in terms of the importance of having the aesthetics of a full hand and their ability to get prostheses in Shandong compared to here in the US.
I think you're right that there's a big potential for that to be there. We see sometimes in the Asian literature incredibly complex microsurgical procedures for hand wounds and partial finger amputations that in general you don't see as much in North America. But that being said, I think a lot depends on how you present it to the patient, how confident the surgeon is. And what we like to do sometimes is we show the patients pictures of past patients we've had, we show them videos, and sometimes we even have patients talk to other patients who've had the procedure. And when they can make a really informed decision, many opt to do this. The patient has to decide, do they want a toe, let's say, or do they want a thumb? And most patients, when you put it to them that way and they see what the results are, they'd rather have the thumb. With other injuries, the answer is more complex. In terms of prostheses, there's an old saying in real estate, and that's applied to hand surgery. The real estate saying is, the three most important things are location, location, location. And the three most important things in hand surgery are sensation, sensation, and sensation. And prostheses won't give you that. And what I've found, and we could talk in detail about the limitations of prostheses, but in general, with time, patients tend to abandon finger and digital prostheses. They're not sensate. They can look good for a while, but they tend to break down over time. They're difficult to put on. You sweat under them. And they just don't function like a toe-to-hand transplant does. And after a while, they figure this out, and I think they're willing to undergo the toe-to-hand transplant.
Raj, what were your thoughts on the article?
Thanks, Lily. I really enjoyed the article. I thought, obviously, it presents, a large series in the big picture of things when you compare it to kind of every other institution's experience on these procedures. It's probably the Bunky Clinic where Dr. Buntic is, and in Shandong. So it's probably the two places where I've seen that have really written extensively on these operations. So it really does present a large series on a rare technique, which is always valuable, even though the numbers aren't big when you compare it to something like breast reconstruction. And I think the other value is just in patient-reported outcomes. Kyle mentioned this as well as you did, Lily, but it's important to have these studies on even rare techniques or rare operations to justify the complexity of why we're doing these operations on patients. In many ways, I agree with Kyle that I found this article very interesting in the sense of learning about some of these techniques and their outcomes, because we don't do a lot of these operations. We certainly have a very, very high traumatic hand volume in St. Louis, but it's very difficult to convince our patients to have these operations done. And I definitely think there are some cultural issues, and it's also issues with just return to work and socioeconomic support as well, and the ability to get rehabilitation. So there's definitely some of those issues as well in our population that we have to consider. So I found the article very interesting. One of the things I wanted to ask Dr. Buntic, it's based kind of on just what operations you're doing or they're doing there, and if there's substantial differences. It obviously becomes challenging statistically to differentiate those out. So this would be more subjective. But in regards to a great toe transfer versus a second toe transfer, and primarily for thumb reconstruction, obviously there's other techniques, third toe transfers for other issues and wraparounds and trim toes. But what is your preferred technique, and has it evolved over time at the Bunky Clinic? And then what are the benefits? With a great toe transfer, you obviously have great stability and motion at the IP joint, but the second toe has a much less noticeable donor site and theoretically more of an aesthetic appeal.
Our preference for a toe-to-thumb transplant is definitely to do the great toe. And the reason is some of the reasons you just touched upon. And I really prefer the aesthetics of the great toe-to-thumb. I think after some time, the great toe changes shape a little bit, it atrophies a little bit, it becomes very similar to the contralateral thumb if the patient has a contralateral thumb in appearance, and it doesn't catch the eye. It becomes very unnoticeable. I think the second toe to thumb, I don't think it is as aesthetically appealing, and we prefer to do the great toe. In terms of the reconstruction of the other fingers, we definitely do the second toe. And one of the biggest things and the most important things is aesthetics. Aesthetics are very important. So we want to make sure that we minimize scarring, that we don't have bulky areas and bulky tissue that we take with us. We want to make the reconstruction as aesthetic as possible, and I think that's sort of a big change that's gone on over the last 10 years or so. We definitely try to make them look really pretty because that is an important aspect to the patient.
I guess one of my questions is sort of similar to some of the points that Kyle and Raj were making, which is I think probably all three of our hospitals have a pretty high volume of hand trauma, and we definitely see our fair share of traumatic finger amputations, thumb included. Do you think that outside of maybe the Bunky Clinic and Changgung, like, are we underselling this surgery, or are we failing to operate on patients with a toe to hand or toe to thumb transfer? Because, you know, like they mentioned, this is sort of a rare procedure for us at Duke. It's not something that we're doing, you know, with the same frequency that we're seeing patients having traumatic finger amputations.
That's a really interesting question. I don't know the answer to that. It is possible that maybe it's not as offered as commonly by surgeons who have less experience in it. It's definitely one of the operations that we really like to do. It's technically demanding, but the success rate is incredibly high. Failures are very few and far between, and patients are very, very satisfied. So we're very happy to promote it and encourage the right patients to have it. One of the other things is, for those who are maybe hesitant to do it or hesitant to encourage it, the slam dunk kind of patient to do is a patient who has a thumb amputation, especially around the MP joint level. As I said before, do they want a toe or do they want a thumb? Most people are going to want a thumb, and the function is going to be terrific.
Maybe that's a better way to sell it, as opposed to this concept of, you know, you're going to have a toe on your hand, which I think can sometimes sound a little vulgar, like off-putting to some patients if you don't have that, you know, experience to show them photographs and videos and have them talk to previous patients and things like that, that, you know, you have at these higher volume center like yours.
One thing I would have liked to have seen in this paper, the paper was great because it presented a lot of data. It had a lot of tables, which I really liked. The graphs were terrific. You really got to see exactly what they did, and they had some nice pictures. They only had one video of a functional result, and they have such a wide experience. Of course, there is limitation. The journal's not going to accept, you know, unlimited amount of videos, but it would have been nice for them to add some more and some different kinds of patients, maybe a toe to thumb, maybe showing a few more activities of daily living, like buttoning a shirt and buckling a belt and tying a shoe, rather than the mechanical things they were doing with the hand therapist.
All right, I think with that, we'll end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune in to the other two articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected article's authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Buntic, for joining us.
Thank you.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.